Welcome everyone to today's webinar, Effective OR Strategy, Driving Out Waste. I'm Emily Rapley with Becker's Hospital Review. We will begin the webinar today with a presentation, and there will be time at the end of the hour for a question and answer session with our speakers. You may submit any questions you have during the webinar through your control panel in the space labeled Enter a Question for Staff and clicking Send. We look forward to hearing your questions. In about a week following the webinar, we will send you a copy of the presentation. This will be sent to the email you used to register. At this time, it is now my pleasure to begin today's webinar by introducing our presenters. Jeff Porobchansky is the Vice President of Supply Chain Operations for Cardinal Health Inventory Management Solutions. As a Lean Six Sigma Black Belt, Jeff has spent the last 10 years of his career at Cardinal Health working with healthcare providers to improve efficiencies and lower costs. Upon joining Cardinal Health, Jeff ran inbound and outbound operations for the National Logistics Center, where he spent time with hospitals optimizing their supply chain until he became a black belt. His full understanding of the supply chain has enabled him to successfully achieve material efficiencies and deliver cost savings through collaborative efforts with hospitals. Prior to joining Cardinal Health, Jeff worked at Target Corporation and in healthcare consulting. Jeff is based in Chicago, Illinois, and graduated from Otterbein University. I'd also like to welcome Carola Endicott. As Vice President of Product Strategy at Cardinal Health Inventory Management Solutions, Carola is responsible for leading solution strategy and product management. Carola was a member of the founding senior team of Wavemark in 2004, which grew into a global enterprise solution for healthcare providers and medical device suppliers, and was acquired by Cardinal Health in August 2013. Before Wavemark, Carola served in hospital administration as Vice President of Clinical Support Services at Tufts New England Medical Center, a Tufts University teaching hospital and academic medical center. Prior to her 13 years at Tufts, Carola was at Massachusetts Eye and Ear Infirmary and Harvard Community Health Plan. Carola holds a master's in organizational development from the Harvard Graduate School of Education and a bachelor's degree from Middlebury College in Vermont. Carola, I'll now turn the floor over to you.
Thank you, Emily, and I'd like to also welcome everyone to the webinar. Jeff and I are looking forward to sharing some best practices with you as it relates to driving out waste in the operating room. You're going to hear us talk a lot about workflow today and data, because we believe those are the keys to unlocking the potential in the OR. And as you can see from the agenda that's up on the screen here, we're going to start with some pain points and then describe the path to get to those actionable insights. So let's get started. Our objectives today are for us to understand the common challenges that we're facing, both as an industry and by operating rooms. How do we create an OR workflow and data capture strategy? And finally, how do we leverage this data to drive out waste? First, let's just do a quick overview of Cardinal Health. As one of the largest healthcare supply chains in North America, we're proud to be ranked in the top 3 by Gartner for the last 7 years. And while the supply chain has been our backbone for more than 40 years, we're also focused on helping our customers successfully reduce the cost of care and drive patient outcomes. Now, let's dig into some of the challenges that we're facing. In this year's advisory board annual reviews, they shared this slide where they're looking at the current state of the healthcare industry and specifically looking at nonprofit hospitals. And what you can see that we're seeing this trend, which I'm sure everybody on the phone is aware of, but I think they did an excellent job of showing where we're heading. We've got this cost curve that will not quit, and we've got the revenue starting to come down. And as we know, it's much more likely we're going to have to bend that cost curve than reimbursements going up. Now, so that's the picture of the past, essentially. How do we look at the future? This is an interesting view of a sample hospital that's pulled together by the advisory board. It's a typical hospital size, probably similar to many of those of you who are on the phone. And in this example showing the margins, we're actually doing okay in 2018, 2019, but if we use assumptions that nothing is going to change and that reimbursement and costs are going to stay on the trajectory they're on now, the problems start showing up in 2021. But unfortunately, that problem gets worse and worse and worse, and we can see by 2025 we've got a $320 million problem that's going to be hard to recover from. I'm betting that most of you on the phone in the hospital someone in your hospital, in the CFO's office, has a chart that looks like this. Now, the good news is that we know it's coming. And this gives us an opportunity to to get our hands around where that waste is and how to drive it out. Now, we're going to talk about the OR in particular, and we're going to talk about financial and patient safety, but I wanted to just take a moment and just tell you a quick story about an additional challenge that we face in the OR. Recently, I was observing workflow in an OR, and it was a cardiac case, and the surgeon called for a device, an implant. The nurse left the room, came rushing back in, and told the doctor that it was the last one, and clearly was relieved that she had one at all. Unfortunately, as she handed the device to the surgeon, she noticed that that it was out of date, that the expiration date had passed actually 3 months before. Now, obviously, she had to tell the surgeon, who was very upset, but given the fact that the patient was on the table and that it was in the best interest of the patient at that time, he proceeded and actually implanted that expired product. They then had to report that in the incident reporting system, and the nurse was frustrated, the doctor was frustrated, and I think the biggest source of their frustration was that they felt this was such a preventable problem. Now, I'm curious actually, for those of you who have joined the webinar today, what your experiences have been. We're going to do a quick poll, and the folks at Becker's have opened up a poll, and I'd like you to just tell us in your current position if you've experienced or heard of others experiencing any of the following problems. We didn't have the product needed for a procedure during a procedure. A recalled or expired product was used on a patient. And number 3, an adverse event occurred because you didn't have the right supplies at the right time. So yeah, we're starting to see the results coming in. We're just going to let that poll run for a couple more minutes, or a couple more seconds. All right, so we've got the poll results where 90% of the people who answered the poll said that they didn't have the right product needed during a procedure. 33% on this webinar said that they've actually seen or heard of a recalled or expired product being used on a patient. And 20% said an adverse event occurred because they didn't have the right supplies. That is a fascinating result. What's really interesting is how it matches up with a recent survey that Cardinal sponsored by Sermo. Let me just take a quick pause and explain the survey. So this was an online survey that went out to healthcare providers. The data was collected in November 2017, so just a few months ago. The sample included a total of 305 respondents, 128 of whom were frontline healthcare providers, a physician or a nurse, for example, in the operating room. So we had some really good data, validated data that came out of the survey, and you might even have seen it. It's been actually in the news. And the respondents represented a range of organizations, size, large and small. And I find as we go through these results that it's particularly interesting if you focus on the dark blue results here, which are the frontline staff who answered the survey. The top portion is really talking about what is the impact on the case delays and cancellations, which obviously have an impact both on patient care but also on the financial outcomes. And here we can see 69% on average, but 74% of frontline staff have had to delay a case because they didn't have the right supplies at the right case at the right time, which is interesting given the results in this survey where 90% said we didn't have the right product when we needed it. And then 44% of the frontline team actually had to cancel a case, which if you can imagine a patient on NPO, waiting for their surgery and then having to cancel, that's obviously not a good outcome for anyone. In the second section of this slide, we can see their answers that were more related to the questions that we asked you today. So 73% of the frontline staff that answered also reported the physician not having a product needed for a procedure versus the 90% on this call. 27%, or around 1 in 4, said a recalled or expired product was used on a patient. So in this case, we had a 33% result. And then finally, a patient experienced an adverse event. So about the same because you didn't have the right supplies at the right time. In our poll today, 20% of you said that. It's very close to the results that we got from their survey. And clearly, this is something we have to get our arms around. So it begs the question, right? We know we have these problems. I'm sure all of you are on this call and then participating in this webinar because you know about these problems. We're not telling you anything you don't know, but what's standing in the way of us solving them?
Thanks, Carola. It's likely not the first time we've heard about the problems or the first time we've tried to solve. They're hard problems to solve, but this industry hasn't shied away from hard problems before. So back to Carola's question, why haven't we solved these problems? We'd like to take a second and get your opinion on it. So we're going to do another survey here. Really quickly, think about your OR and what's standing in the way of progress. Is your staff resistant to change? You don't have supply utilization data from the OR. You're not focused, or we're focused on other priorities outside of the OR. There's no budget for those optimization initiatives in the OR, or number 5, all of the above. We'll give everybody a second to answer, and then we'll recover the results quickly. Looks like we're just about to finish. And here's the results. We see staff resistant to change or all of the above as the 2 top answers from the group. And I think that's very in line with the survey that Carola mentioned. In the survey that Carola referenced earlier, you can see if you look at the right-hand side of this graph, that 58% or just over half of the respondents believe that any effort to save dollars or money in the OR will impact either patient care or their jobs. So you see about 14% said, I'll be under more scrutiny or they'll eliminate my job. 21% believe there'll be an impact on patient care. However, there is hope. If you look at the left side of the graph, 42% understand that money-saving practices help patient staff and their hospitals. And this is where you find your champions. These are the folks that are going to be change agents as we walk through the rest of the presentation today. So we know change is positive, but it certainly can be difficult in an OR. And we can help with that apprehension by focusing on 3 areas: people, process, and technology. First is people. We need to allow clinicians to return to the top of their licensure and take care of patients. The second is we need to remove those clinicians from non-clinical related tasks such as supply management or hunting down supplies in the OR. And third, data that we'll talk about later helps give supply chain the right to partner in the OR and prove that they can make decisions about clinical-based products. The second is process. When you allow systems to operate in a manual process, you introduce variation, defects, and waste. We all have it. Everyone on this call either has someone reporting to them or knows someone in their hospital that searches through all the supplies on the shelf for expired and outdated products. In addition, when there's a recall, we all hope that manual process will allow us to find all of the products we have in stock as we search for them manually. And then in the process piece, capturing those supplies used on a patient at the point of use is key to achieving dollar savings in the OR. And then technology. We all have MMIS systems, clinical systems, EMR, data warehouses that are disparate. We need to find a way to create interoperability between those systems. So you can see if you have the right workflow, the right technology, and the right data capture methodology, we'll create actionable insights to affect change. So how do we create those actionable insights? Again, you have massive amount of data, but it's all stored in those different systems. In this example, it's your MMIS, your clinical system, and your EMR. There's a need to create data, but we first have to create interoperability between those systems. So it starts at being able to track inventory at the point of use. And how do you do that? Obviously, an RFID tag wouldn't necessarily be placed on a pack of gauze. So there's different tracking types for different types of inventory. First, low cost or commodity supplies are tracked through a Kanban system. The second, unique products such as alternative storage or vendor stock items can be tracked by barcode. And the third is those high cost supplies, those physician preference or implantable supplies can be tracked by RFID. All of those pieces are then able to be captured at the point of use, which is most important for people, process, and technology to be able to gather all of that data as a product is being used on a patient.
That sounds good, but ORs are certainly highly complex environments with products flowing in and out from so many different places and sources, whether it's from the rep or from down in SPD or in through the dock. They require a myriad of special handling and storage needs, sterilization, refrigeration, shelves in the core, in the room. How do we take what Jeff just laid out for us and make it real? Because we really need a way, an automated, simple way to track products from the time they come in to the time they're used. So following up on this, we're showing an OR here that has multiple storage options, and in this approach, all these products are being tracked in one system. So although they may have disparate flows in and out, they may be stored in different storage areas. All of that tracking is flowing into one system. They're using the tracking methods described by Jeff, RFID for high-value supplies, stored in both smart cabinets and read by mobile readers, and then simple Kanban for the less expensive products. So if we look at the left-hand side of this, we can zoom in on the smart cabinets. These are great for those high-value implants that must be there. Now, these products would be RFID tagged, and the cabinets are reporting their contents about every hour or more. This way, supply chain professionals can always be sure the implants are not expired, so we don't have that story that I told earlier, and that they're available for use so we can eliminate some of those problems we saw from the survey, both from Sermo and from today's webinar, and we can prevent the issues and get after them. If we now go back into the main area, not all products can be put on a smart cabinet. You've got implants that can sometimes be stored differently, but you also have products that have to be co-located. So if we zoom in on the right side of this picture, how are we going to handle that? Well, we're going to use the RFID because we like the ability to quickly capture lot serial expiration with a simple scan. But what about the low-cost products? And we want to co-locate them because we want to make that pick path as easy as possible, and we want to make the clinician's ability to gather supplies they need as easy as possible. So we can combine the use of RFID by using a mobile reader with Kanban, where we're using barcode shelf signals to make it quick and accurate and easy to both do cycle counts, know what's on the shelf, and also automate the reorder process. If we now go right into the room, in the operating room, we can see in the back of the operating room here, there's a documentation station for supplies. And the beauty of this is that all of those things that we just talked about, whether they're tracked with Kanban, whether they're tracked with RFID or some other method, can be all brought together at the point of use, as Jeff had mentioned earlier. Now, if we zoom in on the point of use for supply capture in the operating room, a third way to capture supplies becomes evident, which is the preference card or the procedure card. Having the procedure card be pre-populated now allows the clinician to either easily waive a product when it's used, either barcode the product if it's not on the procedure card, but for all those items that are already on the procedure card, all they have to do is edit the procedure card and confirm they used what they did use. So if we then go to the next one, it's an interesting question for clinicians at the point of use in the operating room about how much do they actually have to think about supplies. And we believe that they probably have to think too much about supplies. And if there's a way to automate that and build the thinking into the system, we can have the clinicians focus more on the patient on the table and documenting the clinical outcomes of the case. So here you can see an implant record that's popped up because they waived a product that's known in the system as an implant. So they didn't have to know whether it was a supplier or an implant to know which tab or which place to click. It does the work for them and then guides them through the required fields for an implant. And then on the next screen, you see another automated way to capture, to get an alert on a product that's expired. Now, a good OR supply management system will not allow a product to get to this point where it's expired. However, if for some reason it got there, there is one final check that allows the nurse to do a hard stop here and know that this product is expired and should not be used unless there's a clinical reason that must be used. And then finally, at the end of the case, you've now got a complete record of the items used, whether they were procedure card, whether they were add-on supplies, whether they were implants and devices, and we can quickly and easily transfer that information in real time to the OR information system, where the nurse now gets a full and complete view of the products used in the case in their native ORIS and can sign off on the case, and now that case is complete, having used a simple automated method for doing that. So now we've got great data. We've got data from inventory. We've got data from usage. How do we use it?
Let's be honest, we've all had struggles with purchase services, devices and commodities, and pharmaceuticals. But up to this point, we've used purchase data out of our MMIS system to make decisions when we look at price, when we look at mix, and when we look at utilization. So as we focus in on devices and commodities, we use purchase data to make decisions like own versus consigned. And up until this point along the journey, according to the advisory board, we look at price, and on the device commodity market, we have asked our manufacturer partners to work with us on price, work with us through contracting using that purchase data. As we look to move into the next continuum of mix and utilization, right? So the number of vendors we're using in mix and how we're using that product in utilization, it becomes important to move beyond the purchase data and move to the data captured at the point of use that Carola just highlighted. Think about this for a moment. In a typical OR, there are over 200 product categories. 90% of those supplies in the OR are purchased without the help of a centralized purchasing group or of supply chain. In addition, those same 90% are also managed by clinicians or members of the OR staff versus members of the supply chain staff. Part of this data that we're collecting at the point of use, part of the data that we're working to get with interoperability between systems, gives supply chain the right to go to the OR and help them make actionable data insights and decisions through that data. Let's look at some examples of how some health systems have done this. I think up until now, we've talked a little bit about theory of how we're capturing, what to do with that data, but let's look at some actual significant wins and significant cost savings with good data. In the example you see currently on the screen, by using data, one hospital was able to affect $2.3 million of savings on about a $40 million spend and cut down returns by 50%. So not only did they look at the supply spend in those preference cards, and by using real actionable data, were able to optimize their preference cards, they also stopped 50% of those returns going back down to SPD or to the core and having to be returned to stock. In another example, Becker's found that one hospital conducted about 2,200 surgeries a year. The average preference card savings were the average preference card spend was about $1,200. If you do the simple math, that's about $15.8 million a year on med-surg supplies. After they looked at data, there was about $2.9 million worth of product that was open and wasted during those procedures, and another $4.7 million that was not open and had to be returned. If you do the simple math, you find about $1.6 million a year was overspent on supplies. Imagine being able to go back to administration and say, I just saved $1.6 million out of my OR budget by using good data and being able to help optimize my procedure cards. As we look at a second example with product standardization, I've got a quick story to share with the group. About 3 months ago, I was in an OR working with one of the physicians who was really complaining, if you will, about the price of an item that was listed on that documentation station at that point of use, and assured me that the price had to be incorrect. So of course I said, let me look into it, went down to the purchasing department, talked to my contact there, got a copy of the contract and specifically a couple of invoices for the product on the bill only side, went to the ORS system and the MMI system, pulled purchase history on those pieces, and took 5 or 6 pieces of paper back up to the doc and said, actually the price is right, is correct, and if you look at some of these other clinically comparable items, they are priced almost half as much as this item. The doc was infuriated, assured myself and the OR business manager that the rep had told him it was exactly the same price as competitors' product that offered the same clinical outcomes or better. Right at that moment, with just 3 or 4 pieces of paper in his hand, made the decision to not use that product any longer, standardize to what the other docs were using, and go with a completely separate vendor that in his mind offered the same clinical outcomes at half the price. Don't have the total number of savings for the hospital, but just overall, that doc is now won over by clean data being able to present the ability to standardize on products. And this was just one single product. Imagine going back to those 200 product categories and taking control of even just half of that 90% of the spend that isn't controlled by a centralized purchasing group. Imagine the savings that you can find in that data. So as we look at the change journey in the OR, what makes it worth it? Really, when you start to think about patient care and returning those clinicians to the top of their licensure, you really want to focus on prevent expired products from entering anywhere into the OR space. And in addition to that, make sure that recalled products are found and removed from inventory immediately. This goes back to that manual overprocessing. We all do it. We all do cycle counts. We all check inventory. We all look for outdates. We all put little stickers on products and say, use this one first. That's all a manual process. It does help prevent expired products from making its way into the OR suite. It helps recalled products not find their way into the hands of a clinician in a procedure, but it's all still very manual, and that again leaves way for errors. And then again, product availability is paramount. As we look to make these changes, and we saw on the survey that we showed before, there is a fear that we won't have the products necessary to take care of our patients. And that's something that you have to have high availability of products to avoid cancellation of cases and delays and physician frustration. On the other side of the equation, there's certainly an ROI that has to be demonstrated. As Carola talked about earlier, we've got to make sure we can go back to the C-suite and prove that there is a return on investment for this type of solution. Again, meaningful inventory reduction is one piece. Whether you look at that meaningful inventory reduction as an asset or an expense, and whether you look at those write-off from expired product as asset or expense, you still can improve charge capture. You can still work to reduce overstock consignment and have those pieces more in line with your consignment agreement. But there's also a real savings in space. I think we all experience problems in the space in our hospitals, especially our OR. How much is that space worth to get back to include additional products, or actually the right products needed for patient care? So we'd like to take the next step and just ask the audience again through another audience poll of, you know what the status quo is in the OR. We've talked about it a little here. You guys live it almost every day, and we know it has to change. So what are you already doing, or what will you do following this webinar to work to change that status quo in your OR? You collect data using your existing manual processes, meet with your nursing partners to make a plan, conduct an assessment of your current state, or contract internal operational excellence and ask them for help. We'll give everybody a second to answer the poll, and then we'll kind of go over the results. Just a few more seconds here, and we'll have the results finalized.
So it's Carola again, and thanks, Jeff. So 14% saying collect data, 21% meet with my nursing partners, and 52% want to start with an assessment of the current state. Contact internal operation excellence team and ask for help, 13%. I think that makes a lot of sense. The assessment really helps to fine tune and identify where to start. And I think that's always a question. This can seem like a very daunting and monumental task to take on. I think doing an assessment, and we've experienced this also, can really help fine tune the approach and put the resources where they're going to give the biggest return in the fastest way. So thank you so much for participating in the polls. Thank you so much for joining us on the webinar today. I'm going to just wrap it up with these keys for success, and then we'll have time for Q&A. So basically, we've talked about understanding the blockers and levers of change, which, lo and behold, are often related to people. Building support for change, which is obviously a key where data comes in. Having clean data and being able to track that data back to an actual event that took place in an operating room builds huge amounts of credibility for change. Understanding how to then use that data to go even further for collaborative work with those clinicians and with supply chain to look for those improvement opportunities, and as we said in our title of this webinar today, to drive out waste. And then finally, we've said it a lot today, but workflows and good data do unlock the potential in the OR. They are the keys to success, we believe, in the end. So that does it for the presentation part of the webinar. I'm going to turn it back over to Emily, and she will be handling the Q&A, and Jeff and I will do our best to answer your questions.
Thank you so much, Carol and Jeff. That was a really informative presentation. Before we begin our question and answer session, just a quick reminder to our audience, if you have a question, you can submit that by typing it into your control panel in the space labeled Enter a Question for Staff and clicking Send. And we will try to get through as many questions as we have time for today. So it looks like we've got a lot of great questions rolling in, so we'll go ahead and get started. This first question is about OR supply issues. Carola, I will direct this to you. Where do others usually begin when trying to solve for OR supply issues?
Yeah, I think that was one of the earlier questions, because I think this last poll was, that's how I would answer that, is to start with a thorough assessment. Really sort of understand where's the biggest return on investment. One of the interesting things about implementing a supply chain system in your OR is that you actually can start with implants and devices. Even tissue is another place people start. Put your foot in the water. Sometimes start with maybe a segregated piece of the OR. Cardiac is a good place to start. It's got a lot of high-value products. They often are a very cohesive team, and because of all the changes in technology, there may be a good place to start. We've seen that successfully implemented in several operating rooms before. So I guess my answer would be to do the assessment and prioritize based on what you find there. And obviously the people component is huge in the OR. There are places that are more receptive to change than others.
Okay, that makes a lot of sense. So start with the thorough assessment. Let's move on to our next question. We've got an audience member here who says they're already tracking supplies in their Epic module. So I'm sure we've got a few others in the audience on Epic, so I think this is a great question. They would like to know, if they're already tracking supplies in Epic, why would they need to evaluate another solution? And Carol, I'll send this one to you as well.
Yeah, no, we've talked about ORIS systems. Epic is obviously a big one, and we do work very closely with Epic. And I think that in this scenario, what we've heard from the OR nurses who spend their days doing documentation in these ORIS systems, those systems were designed to address the needs of the clinical documentation. And what the nurses have told us is they would prefer to have a tool that allows for easy capture that kind of drives their behavior through what they need to do for supplies. So they don't have to remember, they don't have to try and look stuff up on a separate cheat sheet or do trial and error. They like the idea of having a place that they can simply wave or barcode scan, and those items are recognized by the system because there's a massive product database that it can also drive from. So I think the point of having this in the room adds the richness to the data that supply chain has access to. And obviously then is, in addition to the information that was already acquired about those supplies at the point of receipt and at the point of storage, and gives the entire chain of custody. So we have a clean and automated process for capturing that chain of custody, and we can take it right into the room, and we can look at those trends. And to Jeff's earlier point about going from purchasing data to actual usage data, having all of that in one system has provided amazing eye-opening opportunities for many customers to improve and improve their OR results and drive out waste.
That's a really great point. Thank you. Okay, so let's move to our next question. I think this will be a great one for Jeff. Does this work in other parts of the hospital besides the OR?
Great question. Yes, we focused on the OR today. but the solution works across all departments and bases of inventory. So, for example, of course, the OR, as we've discussed today, works in the procedural areas such as cath lab, IR, also works in nursing floors on commodity items. If you'll remember back to the slide with the different types of tracking devices where we had a Kanban solution for lower dollar commodity supplies, a barcode, or for serialized supplies or vendor supplies, and then the RFID component for those higher dollar physician preference items. Again, I think another important point to make is as you pull that data together, the broader the reach of the solution across all of those types of inventory, the more powerful the data becomes. Again, for use in multiple avenues, such as making those clinical decisions about standardization and mix. So yes, it does work across all types of all types of inventory in the hospital.
Thanks, Jeff. That was a great point with the data. Okay, so let's go to our next question, which is about tissue management. Carol, maybe you can take this one. How do you suggest solving for tissue management?
Yeah, tissue, we get this question a lot. Tissue management is so highly regulated and requires kind of compliance at every step along the route of the arrival at the dock, and obviously if there's a temperature, package integrity, expiration, that tracking has to be done at all of these points along the way. And in our experience, RFID is actually a perfect use case for this because even though surprisingly not all tissue is serialized, most of it is. And what RFID allows for is actually a beautiful serialization of tracking of these products. And if we can make that chain of custody tracking easier, we believe that we'll get higher levels of compliance. And what's interesting to us is that we do still see many paper systems for tissue management. And so we believe that there's a real opportunity here to bring that process into an automated system and to not have a siloed tissue management solution, but actually have that as a component that addresses the tissue-specific needs, but also can be viewed in the context of all of the supplies that are in the hospital and being used. So yes, we do believe that there is a lot of opportunity for tissue management and using these methods that we've talked about today.
Perfect, thank you. Okay, so we'll take one last question, and I think this is a great one to end on. Jeff, can you walk us through this? What is the return on investment?
Of course. So similar to that later slide in the deck around the space savings and all those pieces, let me qualify for you in a very simple statement, then I'll expand a little bit. Typically, we see a 2-to-1 ROI or 2-to-1 return on investment for this solution. I think there's also a piece that's worth mentioning on the left side of that equation, which is the value that it brings, not just in the hard dollars and cents, but the patient care impact, the impact to value analysis teams actually being able to use the data, the clean data that's captured at the point of use. Again, gaining physician alignment and engagement on those standardization and mix opportunities, and then clinical compliance, holding folks accountable to the decisions that VAC committee or the hospital makes. Again, going back to that people, process, and technology, the 2-to-1 ROI is the hard dollar savings, but there's a tremendous amount of value that's also driven from being able to clear up that apprehension that we've seen in the survey around impacting folks' jobs and impacting patient care, around being able to have that high availability. Again, we keyed in on how we get to that ROI savings with a little bit of reduction in supply expense. Again, preference card maintenance, where we saw hospitals save money just by reducing the amount of returns and the amount of product they purchased and didn't use in a case. And then we go back to just those standardization decisions. So again, there's a hard dollar ROI savings about 2-to-1, but there's also that value that's driven with additional ROI or additional savings in value around physician engagement and those pieces. So overall, I think it's one of those things where it is dependent. Sometimes we see a little bit more than that based on how a hospital is managing typically. We find a lot of manual processes in those hospitals. So again, I think as the survey showed as an outcome of this, that assessment is really the first step in understanding how to get after some of these problems. And you're never going to start the journey right, unless you take that first step. So assessment is a great way to start.
Absolutely. Thank you, Jeff. That was really helpful. So that's all the time we have for today. I would like to thank Carola and Jeff. That was an excellent presentation. And thank you to Cardinal Health, who is our webinar sponsor today. To our audience, please enjoy the rest of your day, and we look forward to having you join us for future webinars.